Welcome to the Baptist Health Doc to Doc podcast, a conversation for physicians by physicians, providing insight on the latest in medical practice, research, technology, and innovation in healthcare on the Doc to Doc podcast.
Certain cancers, though treatable, have required women to forego their dreams of having children naturally. The radiation treatment for the pelvis, which can save their lives, can also damage tissue of the uterus and make it difficult to bear children. But now there's a surgical technique called uterine transposition. This surgery allows women who have been diagnosed with cancers in the pelvis and will require radiation treatment to preserve their ability to have their own biological children. Recently, Baptist Health Miami Cancer Institute was the first cancer center in the Southeast region to conduct a successful uterine transposition surgery on a rectal cancer patient. Hello, I'm Dr. John Diaz, Chief of Gynecologic Oncology at Baptist Health Miami Cancer Institute. And joining today is my friend and partner, Dr. Jean-Marie Stephan, a board-certified gynecologic oncologist at Baptist Health Miami Cancer Institute. So Jean-Marie, what is uterine transposition? What's this new procedure that we've developed?
Uterine transposition is a procedure where we're able to detach the uterus from its attachment to the vagina and its anatomical location in the pelvis, lift it up to the upper abdomen where we will reattach it to the abdominal wall, therefore lifting it outside the radiation field, allowing the patient who's going to require radiation to the pelvis to receive radiation without the uterus and the ovaries being exposed to that radiation.
And it's amazing. This reminds me a lot of what we've seen the evolution in surgical oncology. We started with very radical surgery for breast cancer. We did these huge resections and massive lymph node resections. And they had good oncologic outcomes, but the impact on women was devastating. And it was the patient that kind of forced us to find surgeries that would have the same oncologic outcomes, but be less morbid. And we saw this 15 years ago with radical trachelectomies, where we were able to remove the cervical cancer, but women could preserve their fertility. And once again, we're being challenged by patients to kind of find a better way to treat them. So who would be a good candidate for this procedure?
Just to your point quickly, I agree 100% with what you said. I think at some level, as surgical oncologists, we first focus on cancer care and cancer outcome, and we want to cure patients. And we kind of forget or put as a second goal the quality of life post-cancer, especially for our patients who are mostly women, and a lot of them are young women. So we have moved on from just focusing on cancer care. And like you said, our patients have challenged us to think about life after cancer and how we can allow them to have good quality of life, specifically when it pertains to uterine transposition, allowing them to have a family and basically biological children. So what was your question again?
So I was saying, who's a good candidate? Who's a good candidate for uterine transposition?
Right. So any young woman who has cancer in the pelvis, and that could include cervical cancer, vaginal cancer, rectal cancer. The patient that was the first patient that we did this procedure on at the Miami Cancer Institute was a rectal cancer patient. So young woman with cancer in the pelvis whose part of her treatment is going to be radiation therapy to the pelvis.
So it's interesting. This procedure was first described in 2017 by a Brazilian surgical oncologist, but it really hasn't caught on. I went to New York to go observe the procedure on one of our patients. We came back, and shortly after that, you performed the first procedure. And we have a video of what the procedure is like, if you want to talk us through kind of some of the steps in doing this. I was a little bit surprised. It's not too different than what we do every day for a hysterectomy.
Right. I think, when I performed this procedure a few months ago, the first thing that came to my mind following the procedure is, why have I not done this so many times before?
Yeah, I was a little bit surprised how simple it was.
Exactly. Technically, it is not very challenging. Like you said, you can see, on the video, basically the 80% of the first steps are exactly the same steps as a hysterectomy. Some minor differences are in a hysterectomy, major differences, I would say, are preservation of blood supply to the uterus, because we want this uterus and the ovaries to be viable. So short of preserving the blood supply to the uterus, the steps are exactly the same up until the level of what we call the colpotomy, which is detaching the cervix from the vagina. And that is the first, about 80% of what we do in a regular hysterectomy, in a simple hysterectomy. Now the difference becomes lifting the uterus and the ovaries to the upper abdomen and then attaching them to the abdominal wall in an anatomical way that preserves that blood supply from being torced and maintains viability to the tissue. When I was performing the procedure, I found that to be the most technically difficult part of the procedure. Yeah. I see that you've, in your video, you've used ICG green, which I found to be very helpful to allow me to know that this uterus was viable. Is that something you saw as well?
Yeah, we first started doing these fertility-sparing radical trachelectomies about 15 years ago, and there was a concern. If you're taking or sacrificing your arteries, is this uterus or preserving still going to be viable? And so we had done some initial evaluation using ICG green about 15 years ago. And I think we've become more comfortable now using that technique when we do our bowel resections to kind of confirm that we have good, healthy flow. And so that's something that we did here with this first patient, where we give the ICG green and make sure that we see good flow. We're still learning, right? So I get an ultrasound after this procedure just to document flow. A few weeks later, I sent my patient home with Lovenox, anything to just try and prevent clots. I don't know if we need to do this or not, but it seems reasonable to really preserve that blood supply. In my case, for my patient, we had started her on Depo-Lupron, it's a medication that we give, as you know, to kind of shut down the ovaries so that they're not menstruating. I kept the cervix within the uterus. I know you brought the cervix up throughout the umbilicus, so when they menstruate, we wouldn't have spillage into the abdominal cavity. But I think ICG is another technique for us to just confirm what we're seeing anatomically, that yes, the IP ligaments are patent and we're having good flow.
Yeah, absolutely. Like you said, we're still learning. As I was preparing for that case, there's not a lot to look at. There's not a lot that's described in the literature. So it was a question to me as well. Well, what do I do? Is it better to leave the uterus and the cervix intra-abdominally and then shut down the ovaries with Lupron, or bring out the cervix via the umbilicus like a colostomy? So I decided to do it that way and actually placed a colostomy bag on my patient. She menstruated the first, within the first month after the surgery. And then she started on chemotherapy, which automatically shut down her menstruation. She's done with chemotherapy now and is in the process of getting radiation to the pelvis. And then her ovaries kicked back in and she had another period through her umbilicus. So I think that's a viable option. What you did is also a viable option. But over time, the more we do these, the more we offer these to our patients, I think we'll learn what works, what doesn't, and what we're doing that is not entirely necessary, similar to maybe Lovenox.
So it's interesting. My patient, understandably nervous, a young woman with cancer, had this really unique surgery. First time we've done this. I went to the ER at one point because she had some abdominal discomfort. And I got a call from the ER physician that she has a mass in her abdomen. I said, that's her uterus, actually. We moved it up there. So I had some interval imaging between taking her back. We just took her back a few weeks ago, and we have the video from the reanastomosis of the uterus back into the pelvis. And so, as you would expect, we had some scar tissue. You can see here just kind of releasing that. You kind of have to reorient yourself when you get in there and remember that you've kind of tagged the IP ligaments up to the abdomen. At first, you're looking. Also, there's like a pseudomembrane that forms over the cervix as you're taking this down. So you'll see a little bit, we'll kind of release that pseudomembrane. But essentially, it's just releasing the adhesions that you put there on purpose to tag the uterus up, then bringing the uterus back down into the pelvis, and then doing a reanastomosis to the vagina, kind of like we do with our trachelectomy. So again, these are techniques that we're very comfortable doing. Right. And as you said earlier, after you do it, why didn't I think of this before?
Right.
But I think it's a great opportunity to offer this to our patients. In the US, Memorial Sloan Kettering has the largest series of patients, and they've only done 7 of these in about 3 years. So it's really a select group of women who can benefit from this. But certainly it's something we can offer our patients. We've now done 2 just in the last 3 months between you and I. And so I think we're well on our way to offer this to our patients here in South Florida, collaborating with our colorectal team. Most of these patients are rectal cancer patients. In fact, in Sloan Kettering's group, 6 of the 7 were rectal cancers.
What was the last one?
It was my vaginal cancer patient who went there to go observe. Okay. So you can see here, we kind of bring the cervix now back into the vagina.
I'm very curious as to why you sutured the cervix about a centimeter or so in the vagina rather than end to end.
And so with our trachelectomies, as you've done these before, and it's more of an end-to-end, we sometimes get that stenosis, and it can become a little bit difficult. And it's not uncommon with our trachelectomy patients. We have to go back and kind of dilate that cervix. So I want to leave a little bit of a lip of the cervix, kind of the natural way where the cervix protrudes into the vagina and hopefully limit any kind of cervical stenosis. And we just saw her in the office actually this week. The cervix looks great, plenty of accommodation there in the vagina.
Does it look like could you tell she's had a procedure?
Like a normal cervix.
Looks like a normal cervix.
Yeah, 3 weeks post-op. So, care here, obviously, you're going to start anteriorly. You want to avoid the lateral components, which is where you have the remnant of that uterine artery. That's the blood supply that. So once we finished the top, we then went to the backside and completed it posteriorly.
You're using a Stratafix there?
Yeah, using a barbed suture just to kind of make the procedure go a little bit faster. You have to tie these knots. But again, pretty straightforward. Like you said, when you're done, why haven't I thought about this before?
Absolutely. The techniques we've all used in different surgeries in different circumstances. But I think thinking about this is a little bit out of the box. I mean, even though we've had those techniques mastered, when I scheduled that first case, I had to kind of sit and put them all together into one surgery, right? And then imagine the procedure before you go into it. I see here
the ICG green, which demonstrates the flow to the uterus. The uterus is nice and green.
It's a beautiful picture.
And again, we saw her now 3 weeks later, and she's doing fantastic.
Yeah. So patients are I'm sorry, go ahead.
I was saying, who's not a candidate for this? Because now we're, starting to publicize this. I said our colleagues in colorectal are understanding this is a possibility for many of their patients. So in your mind, who's someone that maybe is not an ideal candidate for this?
Well, similar to IVF, I would in vitro fertilization. You have patients that are candidate, patients who are not candidate. We have to be a little bit realistic when it comes to cancer-preserving surgeries, similar to trachelectomies. Classically, we've offered these to patients who are of good reproductive age with good ovarian reserve. 40 is the cutoff that we use in cervical cancer. So I would venture to say that is sort of a cutoff. I mean, it's not an absolute contraindication, but we're doing this to preserve fertility in somebody that wants to get pregnant naturally. So if you're starting off with low chances of getting pregnant naturally, maybe going through the procedure is not for you. Anybody who has uterine cancer, obviously, is not a candidate. And short of that, I think all our young patients who want to have families, I think it's amazing that we can now offer this procedure to them. Even my patient, you mentioned yours, my patient is a 29-year-old who also had had never heard of this procedure, was the first one to get it in Miami or in Florida for that matter. And every time I see her, she's so grateful that we were able to offer her that procedure, her family, her sister, her mother. And then imagine how much we're going to be able to help patients who are in her similar situation. Yeah.
And the other thing I think about is, what are those challenges we sometimes get into the pelvis? Today I did a patient who had a huge fibroid uterus. So I think that might be a relative contraindication. You have to be able to move this uterus and now suspend it up to the abdomen. The last thing we want is to go through all this and have those sutures fail. So I think anything with a large uterine size may pose a problem as we're selecting patients.
I might disagree with you on that.
May be a little bit of a challenge.
I mean, for sure. Endometriosis, I agree. I mean, if the pelvis is frozen, it's going to be hard. But I think these patients who we do this procedure on are going to require C-sections going forward in their deliveries. So I don't foresee, not so distant future, us doing, for example, a myomectomy prior to this procedure.
Yeah.
Doing a myomectomy, closing the uterus, then proceeding with the rest of the transposition. I don't know that is very much far-fetched. What do you think?
Yeah, I don't disagree with you. As we start to see who these patients are that are candidates, and you alluded to this earlier, I think it's important, and we've done this with our fertility patients who are going trachelectomies or some sort of hormone treatment for endometrial cancer, to get our colleagues in reproductive endocrinology and infertility involved early in the process. Right. I think it's important to partner with them, and we're very fortunate at the Miami Cancer to have a robust group of REIs that we work with. But it really is a multidisciplinary approach. This is not just the surgery. This is coordination with their colorectal surgeons, because they're going to need a colorectal resection in the future if these are rectal cancer patients. They're medical oncologists and our reproductive endocrinologists. And so really it's a multidisciplinary team, I think, that has to be involved with these patient care.
Yeah, I agree. That takes me back to something you mentioned earlier when we started. You said, this was done first in 2017 and it hasn't caught up. And I think we have to take responsibility a little bit in that, where we have to promote this a little bit more to our colleagues who see these patients. The colorectal surgeon that I worked with on my patient, as well as the medical oncologist, had never heard of that procedure before, did not know it was an option. And I think the more we talk about it, the more we educate ourselves, educate the patients, educate, the other specialties, we will find that these patients are actually there, but they've not been offered the procedure, and not necessarily with our institute. Even patients from outside Miami Cancer Institute will now know that we do this procedure and will seek it. But we just have to make sure that people are aware and other doctors are aware as well that we can offer this now.
Well, hopefully that's what we're doing today, right? Yeah. We're educating our colleagues. Many OBGYNs have no idea. Right. I know that many have reached out to you after they saw your video. I think it's a great thing that we're being able to offer this, and it's kind of, for me, living through this a second time. We saw this 15 years ago with the trachelectomy. Yeah. Everyone thought it was crazy. What are you doing leaving behind the uterus and someone has cervical cancer? And now we don't even think twice about it. Yeah. It makes so much sense. And so kind of like this technique. So the first time I saw it, I said, this isn't that hard. We can do this.
I would say though, like you, I took post-op MRIs, 2 MRIs, and looking at those images, it is kind of a crazy idea, but then it works, and it offers these patients a new chance of life and having a family, and it's amazing.
Yeah. And so how are you judging success for your patient? So obviously the first success is, hey, the surgery's done.
Right.
Everything went well.
Exactly.
She's obviously going through her treatment now. What are you looking for as you move forward, again, for success in your patient?
Ultimately, we're doing this surgery for a very clear reason, right? These patients want to have a family, biological children. So to me, obviously you want a successful surgery, no complications, healthy patient. But to me, success will translate into a live birth. And granted, there's a lot of factors that play into that. But I think just like any other fertility preserving surgery, success should be judged based on the ability to have kids and actually have kids and deliver them.
Yeah, absolutely. Actually, I was with Mario when the first live baby from Sloan Kettering was born, and he got the text from the patient. We were actually at SGO.
Wow.
We said text. And that's ultimately, right? I mean, success is measured as we go through the first stage of the surgery, the second procedure successful. They've completed their cancer treatment. They start menstruating again. That's a big step, that things are moving in the right direction.
Small wins.
But yeah, I agree with you. That
similar
baby, when you get that picture
yeah. I mean, when
patient.
I get patients' messages or notifications that my patients who I did a trachelectomy on have delivered, I mean, this is when you say, okay, you know what? This was all worth it.
Yeah, absolutely. So where do we go from here with our program? How do we continue to expand? How do we get the message out there, get more patients to be able to benefit from this skill set that we bring?
Education. I mean, just between you and I now, so it's 2 out of our 5 partners. Next, so we're the entire organization knows that we do this now. This has, within Baptist, this was pretty big, right? I mean, I, like you said, I've had colleagues from OBGYNs who've reached out, medical oncologists, colorectal. So within Baptist, I think we've done a good job of putting that out there, saying, hey, we have this new option. Next step is doing what we're doing today, relaying that to other physicians, even outside our institution, and saying, this is an option for these young women, and do not ignore it. This is something we can do, that we have done already. We've done it twice, both of them hopefully so far successful. There's a proven track record, and I think we have to build on that. I'm not sure if there's any, short of educating and promoting awareness, there's something more that we can do. What do you think?
I think we're doing it. And exactly what you said, speaking to those patients, they're going to see these patients. So most of these patients are going to be those younger women with rectal or colon cancers. So, I had a vaginal cancer patient. there's some GYN cancer patients that might benefit from this. But I think when you look at the data, the majority of the women in these series are these rectal cancer or colon cancer patients. So we need to get out there and discuss this with our colorectal surgeons, our GI medical oncologists, make sure they understand that in select women, this may be an option for them. And this is a huge option in that prior to this, we maybe transpose the ovaries,
right?
So they could preserve ovarian function, and maybe even they could preserve their own eggs and have a genetic child. But now this is the ability for them to have, their own child naturally and within their uterus. So I agree with you. Educating, I'll let them know, and continue to work and develop our program here.
Right. Important to mention that when we were doing trachelectomies for cervical cancer, we were worried about oncologic outcomes a little bit. Are we affecting the oncologic outcome? In these situations right now, when we're operating for rectal cancer, for example, we're not interfering with oncological outcomes at all. We're just basically moving something out of the way, allowing complete cancer care and just bringing it back where it belongs. So I think patients and providers should feel very comfortable referring their patients for us to be able to do this procedure.
Yeah, I would agree. So the goal of this surgical innovation is to provide women light in their cancer tunnel, right? Uterine transposition has emerged as an active tool for fertility preservation in women with pelvic malignancies that require radiation therapy. And in the past few years, there's been an increase in young women being diagnosed with colorectal and gynecologic cancers. So the advent of these new techniques is allowing them to now pursue their starting of a family or continuing their family after successful completion of their cancer treatments. So Dr. Stephan, thanks for joining me today in Doc to Doc. It was a pleasure.
Thank you, John.
And thank you, Elle, for having us.
To find out more about the topics covered on the Doc to Doc podcast, please visit physicianresources.baptisthealth.net.